So yes, today we are going to start with the session of clinical anatomy MCQ sessions. Okay, so in this session I am going to discuss anatomy MCQs, which will be having a clinical note added to it, and you have to identify the correct answer, and we will discuss that 10 MCQs are targeted for today's session. So let's start with the session. Okay. So yes, myself Dr. Monalisa. Before starting the session, a brief about myself. So I have got a total of 8 years of teaching experience for various competitive exam. The referral code of mine is ANAT10, which can be used by you for seeing the free sessions on the Unacademy platform and also for taking the subscription of Unacademy. So the free live sessions of Unacademy NEET PG, you can use this code, and you can also use this code for taking subscriptions. So I would also like to give you the information what I have targeted for the next few days, my upcoming session. So I have targeted 2 sessions in the evening, 7:15 p.m. on 15th and 16th of the June. This is absolutely free. So the link will be provided on the Unacademy group Let's Crack NEET PG, and also on the my own group Monalisa Anatomy. My own group, this is the Monalisa Anatomy. This is the session which is taking place on the Unacademy platform, and for unlocking the session, again you have to use the code ANAT10. Those who are seeing the session for the first time, they can use the code ANAT10 for unlocking it. Also my session of free MCQ sessions and discussing the sessions. Okay, yeah, hi, good evening dear Shri, good evening everyone. So also my 9 p.m. session is going on. So today is the 4th session. Until 16th I am taking this session continuously, so you can be the part of 9 p.m. session. Again, this session is on the Unacademy platform. Those who want to join the session, they have to use the code ANAT10 if they want to unlock the free sessions on the Unacademy platform. Now conceptual anatomy sessions are also going on the platform. So conceptual anatomy sessions tomorrow will be continuation of the heart only, and the whole of the thorax I am going to complete on the conceptual anatomy series. So all the best, and before let's start with the sessions now. So I am starting with the first MCQ. All the best to everyone. So this is the first MCQ. Okay, this is the first MCQ. All of you just read the MCQ and mark your answer. So a 62-year-old man comes to the physician complaining of double vision. He first noticed mild difficulty in focusing his eyes approximately 3 weeks ago, and his symptoms have progressed and worsened. The patient other medical problems include metastatic prostate cancer, and neurological examination is unable to adduct his left eye, and stimulation of left cornea does not elicit corneal reflex. So I have underlined the key points which is mentioned in this MCQ. So a lesion involving which of the following anatomical structure is most likely responsible for the patient's symptoms? So you have to mark the correct answer. So Sam is telling it's 1C. So what about others? So all of you just mark this answer, then I will come up with the explanation. So I would like to explain not only the correct answer but also the incorrect option. So we will have the correct and the incorrect option discussion. So whichever field, so Sam has told it's 1C. What about others? Okay, Shri Rangraj is also telling that the answer is C. Okay, the answer is C. Okay. Okay. So Praveen Sinha is telling it's D. It's foramen rotundum. Praveen Sinha, and Akshay Kumar is telling it's C. So okay. So yes, actually the words which is important and which should be marked in this MCQ is the patient is having a complaint of double vision, which is marked. Okay. Also the underline was that he is not able to adduct his left eye, and stimulation of the left cornea is not able to elicit the corneal reflex. These are the key points which is mentioned in this MCQ. Foramen ovale, Savita Kulkarni is telling, actually the correct answer here is C. Correct answer here is C, that is superior orbital fissure. Okay, so let's come up with the explanation of this MCQ. Now the patient here is complaining of diplopia. Now So, and is also not able to adduct his left eye. Adduction of the eye is done by which muscle? Adduction of eye, medial rectus muscle, and adduction of the eye depends on the innervation of medial rectus muscle, that is getting innervation from oculomotor nerve. So, oculomotor nerve is actually originating from oculomotor nucleus of the midbrain, emerges onto the midbrain and then enters and passes through superior-orbital fissure. So, I have marked superior-orbital fissure as the correct answer because the important feature which was mentioned here was the important abnormalities which was seen in the patient was of the third cranial nerve being involved, that is the oculomotor nerve. So, we have got this explanation. Let us move further. So, I would like to show you the same thing in this diagram. Here you can appreciate, yeah. So, oculomotor nerve pathway has been shown, okay. So, the nerve is emerging from the midbrain, then passing through superior orbital fissure. Very clearly you can see here that the nerve is traversing through superior orbital fissure and it is giving, so actually third cranial nerve is supplying all the muscles, all the extraocular muscles of the eye except superior oblique and lateral rectus muscle. So, yes. Now, the patient is also having loss of, so we are already marked the correct answer and very nicely we can see that superior orbital fissure should be the correct answer because loss of adduction is mentioned. So, what about the other features which is mentioned? Patient also have loss of corneal reflex. So, my dear friends, I would like to just give you a brief about corneal reflex. The sensory limb of corneal reflex is mediated via nasociliary branch. Now, nasociliary branch is a branch of which nerve? It is a branch of ophthalmic nerve, and ophthalmic nerve is a branch from trigeminal nerve, fifth cranial nerve. So, this is the sensory. And what about the motor component of corneal reflex? It is by the traversed by the facial nerve. So, what we can feel? So, again the oculomotor, again what we can see, the ophthalmic division of trigeminal nerve via its nasociliary branch is also involved. Okay. Now, once again I want to and we also know that oculomotor nerve nucleus is lying very close to Edinger-Westphal nucleus. So, let me just show you this whole pathway. Here you can see the oculomotor nerve nucleus is located in the midbrain, as in the section of the midbrain we can appreciate. Then passing over and crossing over the superior in close relation to superior cerebral artery reaches the cavernous sinus. It is located in the lateral wall of the cavernous sinus. After that it traverses through superior orbital fissure and it has got superior and lower division and it is supplying all extraocular muscles, superior rectus, it is supplying the medial rectus, levator palpebral superioris, inferior oblique inferior rectus, okay. And closely it is related, one of its closely relation of the oculomotor nerve is by Edinger-Westphal nucleus, which is also related to ciliary ganglion. So, yes, corneal reflex will be also involved if the Edinger-Westphal nucleus and that is also involved. Likely, like the oculomotor nerve, the nasociliary nerve, as we know, one of the afferent component, which was, I have just shown you a diagram where I have told you the written component, the afferent and the efferent. So, we know that the sensory component of corneal reflex afferent is via nasociliary nerve, and nasociliary nerve is also traversing through the middle compartment of superior orbital fissure. So, a lesion which is involving superior orbital fissure will have the resultant of compression of nasociliary nerve and also oculomotor nerve. So, that is quite evident that superior orbital fissure is the correct answer because both oculomotor nerve and nasociliary nerve is passing through superior orbital fissure. So, yes, also we can see the pathway of the innervation, as we can see three pathways. Edinger-Westphal nucleus lying very it is also located very close to oculomotor nerve nucleus in the midbrain, and three pathways has been shown: parasympathetic, sympathetic and sensory. And ultimately what we can see here, the parasympathetic route, that is nerve to inferior oblique, is traversing through ciliary ganglion, synapses here, relays here, and then it gives innervation to constrictor pupillary and ciliaris muscles. So, these are involved for the accommodation reflex and also for the constriction of pupil. So, this is the reason why these are the correct answers. So, much of explanation has been done. Now, my dear friends, I would also like to brief you about the incorrect options. Okay, the other incorrect, why these options are incorrect. One of the option, that is option A, is inferior orbital fissure. So what are the structures जो pass कर रहे हैं inferior orbital fissure से? The maxillary division of trigeminal nerve, the infraorbital vessels and the branches from the sphenopalatine ganglion is passing through inferior orbital fissure, not the oculomotor nerve or nasociliary nerve. So this is not the correct answer. Now also seeing the orbital hole index and the openings and the structures lying, we can see here in the inferior orbital fissure the structure traversing is infraorbital nerve and vessels, and infraorbital nerve is there, zygomatic nerve is there, infraorbital vessels is there, but not the third cranial nerve and the nasociliary nerve. Now this whole fissure which you are seeing, this is the whole fissure which you are seeing is of superior orbital fissure, and through the middle part of superior orbital fissure both superior and inferior division of third cranial nerve and nasociliary nerve is traversing. So this is the reason the correct answer is superior orbital fissure. Okay, so this diagram is showing you the structure, so all of you can revise the structures passing through superior orbital fissure and that of inferior orbital fissure. Now what about the other options? So one of the option was optic canal. So what structure passes through optic canal? Two structures, ophthalmic artery and optic nerve. Okay, so optic canal, we can see here, this is the opening of optic canal and the structures traversing is optic nerve and ophthalmic artery, which is not involved in the clinical picture mentioned in the patient. So this can't be the correct answer. Now moving on to the next option, this was again an incorrect option, that is foramen rotundum. So foramen rotundum, again here in this diagram foramen rotundum is shown, this is foramen rotundum. The structures traversing is maxillary nerve. Maxillary nerve division of trigeminal nerve is passing through foramen rotundum to reach the pterygopalatine fossa, and it in its course it traverses through inferior orbital fissure and then emerges out from the infraorbital foramen as infraorbital nerve. So these structures are not involved and the clinical symptoms which was presented in the patient was not confining to that of maxillary nerve. So this can't be the correct answer. Now the other option was foramen lacerum. So my dear friends, generally foramen lacerum is occluded at times by cartilage, and the important structure which is coursing through it is the internal carotid artery. Internal carotid artery is coursing through foramen lacerum ultimately to reach the carotid canal. So this was not compressed and this was not mentioned in the MCQ. So this can't be the correct answer. Now one of the option was foramen ovale. My dear friends, through foramen ovale the structures traversing is male, mandibular nerve, accessory middle meningeal artery, lesser petrosal nerve and emissary vein. Okay, mandibular nerve, accessory middle meningeal artery, lesser petrosal nerve and emissary vein. So none of this structure was, this is foramen ovale, none of this structure was compressed, and the sign of symptom was consistent with the compression of mandibular nerve. So this can't be the correct answer. So I think this explanation is enough. Everyone, can we move on to the next MCQ? So we have just gone through the explanation of first MCQ in much detail, not only the correct one but also the incorrect one also. So for the clinical MCQs, I will also explain the incorrect options so that we can have a clear picture of the MCQ. So let's move on to the second MCQ. So a 36-year-old man rushes to the emergency department after the sudden onset of shortness of breath and difficulty in swallowing. He has visited the emergency department several times before food and skin allergies. He is unconscious on the arrival. Examination shows excessive accessory respiratory muscles and edematous swelling of the face, lips and tongues. There is also scattered utric area over the upper body. Attempts of intubation are unsuccessful. So key feature, attempt of intubation is unsuccessful in the patient due to massive soft tissue edema involving the pharynx region. So a decision has to be made so that we can perform emergency cricothyroidotomy. Okay, cricothyroidotomy has to be performed because there is unsuccessful failure of intubation. So the incision should be made in this procedure, and this should pass through which of the following structure. So here 5 options are there. All of you, buccopharyngeal fascia and platysma is there. Platysma or thyroid isthmus, pretracheal fascia cricoid cartilage, pretracheal fascia prevertebral fascia, or superficial cervical fascia and cricothyroid membrane. So according to you, which is the most correct answer? So all of you just mark your answer. what you feel which is the most correct. There are 5 options, my dear friends, and just mark the correct answer. The whole clinical history of the patient is mentioned here. So, whichever you feel is the correct, mark your answer. Okay, so yes, Sarans Acharya is telling it's E. What about others? So, side 3, okay. So, A, B, C, D, E is the option. So, you can mark like that. Okay, so what about others? What about others? So, everyone, whichever you feel is correct, mark the answer. Otherwise, I will come up with the explanation. Don't worry about this. So, yes, A, okay, A. What about others? A, E. So, Sam is also telling it's E. Sam is also telling it's E. So, yes, let me explain this MCQ. Actually, the whole MCQ clinical history you must have just gone through it. I would like to tell you the key points which is mentioned in this MCQ. Firstly, we have to target the key points. Okay. So, yes, Rangaraj is also telling it's A. Actually, the correct answer is E, my dear friends. So, Sam is right and Acharya is right, Sarans Acharya. E is the correct answer. Don't worry, I will come up with the explanation, not only the correct and also the incorrect option. So, let me just explain it. The first thing which I want everyone to target in this MCQ is the keywords which is mentioned. So, we have to target the keywords which will help us to approach to the correct answer. The keywords is the history of the patient of sudden shortness of breath and difficulty in swallowing, excessive use of accessory muscles of respiration, edematous swelling of the face, tongue, scattered urticaria about the body. So, also unsuccessful intubation is there, and we have to go for emergency cricothyrotomy. So, we have to choose the incision and which structures will be incised so that we can go for emergency cricothyrotomy. So, these are the keywords which should be kept in mind while solving this MCQ. Now, the patient is, everyone, what is the patient is suffering from? What is the patient? The history is basically telling you the important point is that the patient is suffering from acute laryngeal edema, anaphylactic reaction. Patient is going through anaphylactic reaction and he is exposed to allergens. Okay. So, there is edematous swelling, laryngeal edema. Can you see the arrow marked area there in this diagram? We can clearly see there is okay. So, we can clearly see there is the laryngeal edema is there. Laryngeal edema is initially present with when there is laryngeal edema, the patient will have dyspnea, hoarseness of voice will be there, difficulty in swallowing will be there, throat tightness will be there, and ultimately if the swelling is enlarging so much, ultimately what will happen? It can cause asphyxia or airway compression can occur. So, more difficult situation can be there. So, now the next point is that ultimately what we have to do, we have to go for cricothyroidotomy is indicated. So, it is indicated in emergency condition when we want that in that condition where there is unsuccessful intubation. So, in this patient also what we have seen along the clinical scenario that the patient was having unsuccessful intubation, orotracheal or nasotracheal intubation is not successful. Maybe the reason will be due to a large swelling, or at times it is contraindicated also when the patient is having any kind of airway obstruction, facial trauma, massive hemorrhages. So, ultimately we have to go for cricothyroidotomy. So, here you can see the patient cricothyroid membrane has been palpated and we want to palpate the cricoid cartilage and ultimately we want to put the incision here. So, I would like to, what was the answer which we have to give was to procedure which is has to be done and which structure has to be incised. Now, the procedure is to establish, what is the procedure? Ultimate goal is to establish an airway, placement of the tube, we have to put the tube and we have to cut actually the exact location of tube being introduced is exactly between the cricoid and that of thyroid cartilage. Okay, we want to put, as you can see in this diagram also, this is the neckline. So everyone, I am just highlighting this diagram. Okay, so this red color line is the line which is exactly, if you will see the line location is, the location of the line is exactly between the thyroid cartilage, okay, and that of, this is the cricoid cartilage. Okay, so cricothyroid membrane has to be approached. Which membrane? Cricothyroid membrane has to be approached and has to be incised for this emergency procedure. Okay, now coming to the explanation once more, the things. Okay, so the structures being incised are, the structures which is being incised are, firstly the skin, yes, obviously the skin, superficial cervical fascia including the platysma muscle and the subcutaneous fat. Platysma muscle, a muscle located in the superficial fascia, panniculus carnosus. Then we are approaching the pretracheal layer and investing layer of deep cervical fascia, and the ultimate goal is to pierce the membrane. Which membrane? Cricothyroid membrane. Cricothyroid membrane. So for the correct answer, we have to go for the piercing of cricothyroid membrane and that of the superficial cervical fascia. So this is the correct answer. So in this option, let me move to the correct answer now once more. So only option A is correct. Why? We have to approach. Now we have seen that in case of performing emergency cricothyrotomy, we have to approach to the level of, cricothyroid membrane. Exactly, the incision should be in the cricothyroid membrane. So we will pierce superficial cervical fascia and cricothyroid membrane. Now let's move on to the incorrect options. So we have got 4 incorrect options. So just one line each about that, why they are incorrect. So you must be confused with that option. So let me rule out that options. So we have already approached for the correct option. Now let me rule out the incorrect option. One of the option A was buccopharyngeal fascia and platysma. My dear friends, buccopharyngeal fascia is extending from carotid sheath and it is covering pharyngeal constrictor muscles. Okay, so we don't have to go such posterior. So please mark in your mind that buccopharyngeal membrane is much posteriorly and we have to not go to that space. Actually, the buccopharyngeal membrane is lying anterior to prevertebral fascia. So we are not going so posterior to prevertebral fascia. So it's no need to go for buccopharyngeal fascia incision. So infections, actually the infection which is involving retropharyngeal space, okay, that can traverse in this area and also can involve superior mediastinum and can cause the inflammation or involvement of mediastinum. Necrotizing mediastinitis can happen. So we are not going such posterior, we are not going to approach for prevertebral fascia, we are not want to approach superior mediastinum, so we will not go such deep, okay. So I also want to show you, as I told you, my dear friends, actually many of this has been come as an MCQ session also in the previous year examination of NEET PG pattern MCQ. So I just want you to show the 2 areas, the retropharyngeal space and the danger area. Actually many students at times they get confused between these 2 spaces. Actually these 2 spaces are different. You have to know the difference between the retropharyngeal space and that of the danger space. My dear friends, danger space has been shown with red color and retropharyngeal space is shown by yellow color. My dear friends, retropharyngeal space is lying anterior to danger space. All of you just concentrate on that diagram. Can you see 2 spaces has been shown, one with the yellow color and the other with the red color. So we have got the location of retropharyngeal space anterior to danger space, means it is lying anterior to the alar part of deep cervical fascia. Exact location of danger space is between prevertebral fascia and that of alar fascia. So danger space is lying between which 2 layer? All of you, danger space is lying between which 2 fascia? One is the alar portion of deep cervical fascia and the other is the prevertebral fascia. Now just anterior to this, if you move just anterior to this, we have got retropharyngeal fascia and the exact covering of retropharyngeal fascia is between the buccopharyngeal fascia and alar fascia. Retropharyngeal fascia is lying anterior to danger space of neck and it is exactly lying anterior to the danger space and it is exactly lying between the alar portion and buccopharyngeal fascia. Is it clear from the diagram, everyone? Is it clear to everyone the difference between the retropharyngeal space and that of danger space of the neck? Is it clear? Now, The other choices which was mentioned here, so two more choices were there. One was platysma and thyroid isthmus, and other was piercing pretracheal fascia and cricoid cartilage. My dear friend, cricoid cartilage is not pierced, okay. Why? Because cricoid cartilage is lying inferior to thyroid cartilage, and exactly we are going to make a nick in between the cricoid and that of thyroid cartilage. We are not going to cut the cricoid cartilage. So in case of when the cricothyrotomy has to be performed, in no way we are going to cut thyroid isthmus, we are not going to cut thyroid isthmus, we are not going to cut the cricoid cartilage. So this is the reason these two these can't be the correct answer. Okay. Now moving on to, just let me show you once more, I just want to show you this diagram. So here you can see the thyroid cartilage is shown very nicely, T for thyroid cartilage, and this is the C for cricoid cartilage, and exactly the nick which has to be put in between these two layers. The nick has to be put between here. The nick has to be put here. That is cricothyroid membrane, the membrane which is lying between the thyroid and cricoid cartilage. So why to cut cricoid cartilage or thyroid isthmus? Yes. So what about the other option, that is pretracheal fascia and prevertebral fascia, that is option D. Actually pretracheal fascia and prevertebral fascia, we know that deep cervical fascia is having three layers: investing layer, pretracheal layer and prevertebral layer. Now prevertebral layer is very deep, is lying on the deeper aspect, and we are not going to cut or make an incision in the deeper layer of deep cervical fascia. So it can't be cut in the procedure of cricothyrotomy. So see here, so we have done with the correct answer and also incorrect option. Once more I have included this diagram so that you can revise the layers of the deep cervical fascia in the sagittal section and also in the transverse section. So here we can see the prevertebral space, the danger space and retropharyngeal space nicely. Okay. So you can see here the three spaces. So we can see retropharyngeal space, the danger space. You can, in this transverse section also you can see the retropharyngeal space is lying anterior to danger space. Okay, so these are the spaces which is quite evident here. Now other diagram which I have included is the sagittal section, where you can see the prevertebral space, danger space and retropharyngeal space. So three arrows has been demarcated. So please refer this diagram. You can just refer this diagram once more. I am including that diagram in one piece. Okay. So three colors has been used. Okay. The yellow color is for the deep prevertebral layer, pink color is for pretracheal or middle layer, and blue color is for investing layer of deep cervical fascia. And also the three spaces that is usually confused. So exact location I have shown here with the arrow mark. You have to know the difference between mainly the danger space and retropharyngeal space, and most posteriorly is the prevertebral space. So I think, is it clear everyone? Can we move on to next MCQ? Okay. So in brief, I have shown you the diagram where the layers of deep cervical fascia and the content of these spaces has been shown. If you want, you just let me know. I can also take a session on deep cervical fascia and its layers. Let's move on to the next MCQ, that is MCQ number 3rd. So all of you, okay. Yes, Acharya. A 67-year-old woman having metastatic lung cancer complains of recent hoarseness and difficulty and swallowing. On examination, there is loss of gag reflex. Okay, the patient is complaining of loss of gag reflex onto the left side and uvula deviated to the right side. When the patient is prompted to say ah, okay. So when the patient, we just tell the patient to prompt the word ah, and we see the deviation of uvula and also the gag reflex. There is also weakness of her left sternocleidomastoid and trapezius muscle. So a lesion involving which of the following anatomical structure is most likely consistent with the patient's symptoms? So 6 options are there, and please mark the correct answer. So according to you, the clinical history of patient has been done and all the features has been mentioned. So you can tell me the right answer. Sam is telling F. What about others? Yeah, Gopika Sarma, jugular foramen. Okay, many Sarans is also selling its F. So in clinical question at times it becomes easy also because so much of clinical hints are given to approach the right answer. So that is the point. Yeah. So yes, all of you are absolutely right. The correct answer is jugular foramen. Okay. What is the syndrome the patient is suffering from? What is the syndrome the patient is suffering from? What is the syndrome, dear? Yes, Mandy, you are also right. What is the syndrome the patient is suffering from? Anyone? Patient syndrome. What is the name of that syndrome the patient is suffering from? It's the jugular foramen syndrome or Wernicke syndrome. Okay, it's jugular foramen or Wernicke syndrome. So let me explain. The patient symptom is consistent with the lesion involving jugular foramen. Okay, and it's lying on the base of the skull behind the carotid canal is the location. The structure which is traversing through jugular foramen is 9th, 10th and 11th cranial nerve. The structure which is traversing through it is 9th, 10th and 11th cranial nerve, and lesion in the jugular foramen from any kind of tumor, any kind of trauma, any kind of infection can lead to a syndrome. The name of that syndrome is jugular foramen or syndrome or Wernicke syndrome. So all of you please note this point, this is important. The name of the syndrome is Wernicke syndrome, which is also called as jugular foramen syndrome. And the characteristic involvement is, yes, now I got the answer, Gopika Sama, Wernicke syndrome. Yes, the characteristic involvement is 9th, 10th and 11th cranial nerve. So there will be dysfunction of 9th, 10th and 11th cranial nerve. So yes. Now firstly I would like to show you, this is the basal aspect of the skull which you are seeing, and I want to show you the fossa, that is the jugular fossa here. Okay. Now we want basically let's move on to this important symptoms which is related. So actually the symptoms which is related with the patient and the nerve affected is, the patient will have, actually we know that structures traversing through jugular foramen, everyone must be knowing it's 9th, 10th and 11th cranial nerve. 9th, 10th and 11th cranial nerve is basically, so the sign and symptoms will be consistent with the involvement of these structures. Okay. So there will be dysphagia, hoarseness of voice, loss of gag reflex and shoulder dysfunction. Okay, loss of taste sensation from posterior one. So what is the sign and symptoms? I have written the sign and symptoms of the patient. If the patient is having Wernicke syndrome, the patient will be having loss of taste sensation from the posterior aspect of the tongue, reduced parotid secretion also due to involvement of 9th cranial nerve, loss of gag reflex because of the involvement of both 9th and 10th cranial nerve, dysphagia will be due to difficulty in swallowing, that is 9th and 10th, dysphonia will be due to involvement of 10th cranial nerve, soft palate and the deviation of uvula is occurring towards the normal sized, again this is involvement of 10th cranial nerve. And my dear friends, we already know that two of the muscle which is getting innervation from accessory nerve is the sternocleidomastoid and trapezius muscle. So yes, these are the sign and symptoms which will be seen if the patient is having or patient is suffering from the compression of jugular foramen, which is causing compression of mainly 9th, 10th and 11th cranial nerve, Wernicke syndrome. Now, my dear friends, I also want to tell why the other options are not correct. The other option was cribriform plate, foramen ovale, foramen rotundum, internal acoustic meatus and hypoglossal canal. So in this foramen, 9th and 10th and 11th nerve is not traversing. Okay. For example, when we are talking about cribriform plate, the olfactory nerve rootlets will be involved. When I am talking about foramen ovale, when I am talking about foramen ovale, so what will happen? Mandibular nerve will be involved. When I am talking about foramen rotundum, maxillary nerve, hypoglossal nerve, 12th cranial nerve, internal acoustic meatus, 7th and 8th cranial nerve. So the sign and symptoms is not consistent with the involvement of these nerves which is passing through this foramen. So this is the incorrect option. Is it okay? So this is the reason these are incorrect option. So everyone, can we move on to the next MCQ, MCQ number 4th? Okay. So yes. Okay, a 30-year-old male present to the emergency room after being involved in a street fight. All of you just see this. This is a clinical and image based MCQ, both mixture of it. So, a 30-year-old male is presenting to emergency department by involvement of after being involved in a street fight. There is significant soft tissue swelling around the eyes. Okay, the imaging study is showing that accumulation of fluid. So you just tell me by seeing this image that accumulation of fluid is seen in which of the following sinus? Which of the following sinus? Accumulation of fluid is seen in which of the following sinuses? Ethmoidal, maxillary, frontal, sphenoid or inferior concha. Inferior concha is actually, so you just mark the correct answer. Maxillary sinus, Sam is telling, yeah. So it is clearly seen in this diagram also. We know that air spaces are, so can anybody tell me air spaces are? Blowout fracture, yes, it's commonly involved. When there is a blow, it can be involving the floor. It can be involving the floor of orbit and can lead to the fracture of floor and involving maxillary sinus. So actually most of you, so only 1 or 2 answers are coming. You just mark the answer so that I can explain the answer. Gopika Sharma B. Okay, Gopika is telling us B. What about others? So yes, few students has given the answer. The correct answer is B, maxillary sinus. Okay, so we know that air is appearing black and the whole opaque region is seen here. So opaque region is seen here. So that is due to the trauma and accumulation of fluid, blood or fluid is accumulated. So involvement of maxillary sinus is seen. Now the orbit is bounded. I would like to just give you a brief about the boundaries of orbit. The orbit is bounded superiorly by thick orbital plate of the frontal bone, laterally by the zygomatic bone, and also it is also bounded by the sphenoid bone. Now my dear friends, I just want to tell, if you will see the floor of the orbit, it is just separated by a very thin film of thin plate of the bone which is separating the orbit from air filled maxillary sinus. Which? Air filled maxillary sinus. Air filled maxillary sinus. Okay. Yes, Amrit Hajra, B is correct. Now orbital wall is composed of thin bones like ethmoidal bones, lacrimal bones, also maxillary bones. These are very thin and at times a direct blow or punch is given into the orbit. There can be fracture of the thin plate of bone. Actually on the medial aspect also lamina praepacia is lying a thin plate of bone between ethmoidal air sinuses and that of orbital margin in the medial aspect. Lower aspect we have got orbital maxillary sinus involved. So these can be involved, which was quite evident in the diagram also. Now in this diagram, this is a very diagram in which different colors has been used so that you can appreciate the boundaries of the orbit. So yellow color bone which you are seeing, my dear friends, this is the frontal which has been shown. This is the frontal bone, this is the frontal bone. Okay, lower down this part of the bone which you are seeing here is the maxillary bone in the purple color. The blue color is the zygomatic bone. Okay, this is the nasal bone. Exactly, nasal bone is not forming the boundary for orbit, but we can see small part of this bone is the palatine bone. A small piece of palatine bone is also seen. Also we can see the part of lacrimal bone. This is the lacrimal bone medially. Okay, also we can see this is S for sphenoid bone. Okay, so basal part of the bone and the brown color is E for ethmoid bone. So see here, these are the bones which is whole forming the boundary. So color has been demarcated and nasal bone is shown in the diagram, but nasal bone is not forming the boundary for the orbit, and the important bone very easily getting ruptured or fractured are mainly the maxilla bone, the lacrimal bone. These are very easily fractured. Also a thin plate of bone which is separating ethmoidal air sinus and the orbit is the lamina, lamina praepacia. So that all can at times get affected. So all of you just revise the boundaries of the orbit. Now here in this patient, what happens, generally air containing structures will look, everyone, air containing structures kaisa look hota hai, they are blackish, and here a very here in this diagram you can see a good collection of fluid has been shown here. So in this area the fluid or rupture of the orbital has been done of the orbital floor. The floor of the orbit is involved, and what will be the sinus involved? The sinus involved is the maxillary sinus. So this is the reason, this is the correct answer. Blunt trauma to the eye causes rapid increase and transmission posteriorly to that of the orbit. Weakened plate of bones are affected, and medial and inferior wall. Medial wall is mainly formed by lacrimal bone, okay, and inferiorly by the maxillary bone. So fracture will be typically evident, and fluid and blood can be seen in normally air filled. Normally sinuses क्या होता है, air filled structures होता है, they are pneumatic bones, but at times if there is blow or there is collection of fluid, there is collection of pus, there is collection of blood, then it will not appear blackish, but it will appear opaque. So here in this image the maxillary sinus is involved, which is filled with fluid, okay. Now my dear friends, now let me tell you, so we have done with the correct answer, all of you, we have already done with the correct answer, but what about the incorrect option? So I just want to show you few diagrams so that you can be able to locate the sinuses when you get image based MCQs. So ethmoidal air sinuses is lying medial to the orbit. Okay, we have already finished one. I have also discussed in few of my session lamina pepracia and all, a very thin plate of the bone which is separating ethmoidal air sinus and that of orbit. I think a few students must be remembering that also. Yes, absolutely right. So here what happens, ethmoidal air sinus is lying medial to the orbit, so it was not. What was the structure involved? The structure which was involved in the patient was inferior, means floor of the orbit, not the medial wall. So it is unaffected, so this can't be the correct answer. See, this is the enlarged view of the diagram. So see here you can clearly see, this is the ethmoidal air sinuses, and here you can see ethmoidal air sinuses are located here. It is lying medially. Actually the location of ethmoidal air sinuses are these, and this is lying medial to that of orbit, okay. And also nasal concha can't be involved. Actually nasal concha also not, inferior nasal turbinate and concha was also mentioned, that is this is inferior, actually this part is inferior nasal turbinate, and it was also not involved, as we can see in this diagram. Now moving to the next, frontal air sinuses. My dear, just locate the frontal air sinus. It is lying superior to the orbit. If you will see, if this is the orbit, so frontal air sinus is lying superior to the orbit, and this was also not involved in the MCQ. Now moving to the sphenoidal air sinus. If you will see the location of sphenoidal air sinuses, you can see the location of sphenoidal air sinuses is lying posterior to the orbit. Sphenoidal air sinus, let me just show you this diagram. Okay, so just see here, this is the sphenoidal air sinus, and the location is, if this is the orbit, so more located, it is going more posteriorly in location to the orbit, not inferiorly. The structure involved was inferiorly, so the correct answer was maxillary sinus. So one more diagram is here, and here also let's see the sphenoidal air sinus location. This opening is sphenoidal air sinuses, okay, and here is the location, okay. Here is the location. Now let me show you, okay, the other option was inferior nasal bone or terminate. So I have shown you that diagram also. Can you see the inferior nasal bone or terminate is a different structure, and generally it is a bone, so it is not air filled. This is not air filled, and this is lying more lower aspect, and it is actually lying in the lateral wall. It is actually located in the lateral wall of nasal cavity, and it can't be involved inferiorly. The bone which was involved was maxilla. So maxilla is the correct answer. So I think this explanation is okay. Can we move on to next MCQ, everyone? Can we move on to next MCQ, MCQ number 5th? Okay. So let's move on to MCQ number 5th. Yeah. So all of you just go through this MCQ. A patient is recovering from a traumatic injury to the face, now find himself to chew his food. The patient is not able to chew his food. On physical examination, his jaw deviates to the right side. Jaw deviation to the right side. The nerve that has been injured in this patient exit the skull through which of the following foramina? Okay, so the clinical presentation of the patient has been shown. You have to tell me the correct answer. Go for the answer. Question number 5th. So mixed bundle of answers are coming up. Okay. Sarah's Acharya answer is B. Okay, Sam is telling it's B. What about others? Okay, so Meet is telling it's B. So actually you can find it, it's by the name only it appears that clinical MCQs are difficult, but actually if you have an idea of gross anatomy, clinical MCQs are easy because all the hint are provided in the MCQ. Actually answer is given in the MCQ only by the clinical history. Ayush Kumar is telling it's B. Okay. Rangaraj is telling it's B. Meet is telling it's B. Jay is telling it's B. Actually the correct answer is also B. Okay, the key feature which I have underlined the key feature is in the MCQ. So the patient is unable to chew his food, means mastication muscle is involved, masticatory muscle is involved. And my dear friends, I have also taken a session on the masticatory muscles, and we know that muscles of mastication is getting innervation from which nerve? It's getting innervation from which nerve? It is getting innervation from mandibular division of trigeminal nerve. And mandibular division of trigeminal nerve, mandibular division of trigeminal nerve, B is correct here. Mandibular division of trigeminal nerve is passing through foramen ovale. So let's come up with the explanation. So yes, the patient has, yeah, I understood. You have given, Dr. Animesh, you have given the right answer. I understood, by mistake it must happen. The patient is consistent with the injury of third division of trigeminal nerve, that is mandibular nerve. Which nerve is involved? Mandibular nerve is involved, mandibular nerve, and this mandibular nerve is important for giving innervation. It is mainly giving motor innervation to masticatory muscle and also lower part of the face. Lower part of the face from here to here, this area is getting sensory division, sensory innervation from mandibular division of trigeminal nerve. Yes, male. So my dear friends, we can clearly see in this diagram that mandibular nerve, okay, mandibular nerve, that is actually not a confusion for this MCQ. On his jaw deviates to the right side. Okay, his jaw deviates to the right side. So actually none of the option which is mentioned here is jugular foramen, foramen lacerum, foramen spinosum, foramen rotum. None of these involves mandibular nerve. So that can be the correct answer. Now let's come up. Firstly, I want to show you this mandibular nerve whole course. So mandibular nerve, branch of trigeminal nerve, it is giving from its trunk, it is giving the branches. Actually, it is giving it's giving a branch here from the trunk, which is foramen spinosum se pass on kar raha hai, nervous spinosum, okay, and also nerve to medial pterygoid has been given, and also it gives anterior divisions, a deep temporal nerve, buccal, lateral pterygoid, masseteric nerves, and also it is giving sensory nerves, inferior alveolar nerve, okay, inferior alveolar nerve, okay. Now, inferior alveolar nerve, nerve to mylohyoid is also given. We have got other division, that is auriculotemporal nerve, okay, auriculotemporal nerve, lingual nerve, okay. that all nerves are involved. So we can clearly see here that mandibular nerve is providing innervation to, mandibular nerve is giving innervation to muscles of mastication. What is the name of muscles of mastication? Masseter, temporalis, buccinator, okay, buccinator and all. So side to side movements, okay, my dear friends. Now deviates, as we know that medial and lateral side to side movement is done by which muscle, dear? Okay, Sub Ali, side to side movement is done by medial and lateral pterygoid muscle. So that depends on which side of the nerve is involved. Okay, that was not mentioned in this MCQ. Only the thing which was mentioned was deviation, but it is not side specific, but we know that we have got alternate contraction of both the side by medial and lateral pterygoid muscles being involved. Okay, ultimate the medial and lateral side or side to side chewing is done, and it involves whether medial pterygoid muscle or lateral pterygoid muscle is involved, but altogether all of these masticatory muscle is involved only when we talk about the lateral pterygoid muscle, which is involved in opening of the mouth. Okay, this is what opening of the mouth, that is depression is done. Now otherwise protrusion is done by temporalis, masseter, medial pterygoid. Okay, medial pterygoid. Okay, so other side here we have got muscles of mastication being involved. The muscles of mastication, as you can see here, we have got medial pterygoid, we have got masseter, temporalis. Temporalis muscle fibers are involved for retraction action. It is causing retraction of the mandible. We have got temporalis muscle, which is supplied by deep temporal nerve. Side to side movement is done by medial and lateral pterygoid muscle. Okay. Done? Okay, Ali, what was your doubt? Okay, I didn't got it. What was your doubt? The patient is unable. Now, my dear friends, only the correct option which we can clearly see what is the answer. The patient who is unable to chew the food means the patient is involving masticatory muscle, and there will be jaw deviation is likely suffered due to weakness, and jaw deviation is likely to be injury to the mandibular nerve. Is due to the injury of mandibular nerve. Okay, which is involved by the involvement of mandibular nerve. Okay. Now let's move on to the incorrect option. Okay, that is by we can go for side to side movement by medial and lateral pterygoid muscle being involved. Okay, medial contralateral involvement, medial and lateral side of the muscle. So one of the side of the medial or lateral pterygoid muscle is involved. So it will lead to side to side movements. Okay, that is involvement. Okay, now let's move on to the next one. That is the mandibular division of trigeminal nerve. Okay, now when we move on to the mandibular division of trigeminal nerve is exiting through the foramen ovale, and other than the structures which is all other involving is the male structures. From foramen ovale, which structure is passing from foramen ovale, the structures traversing is male. Mandibular division, accessory meningeal artery, lesser petrosal nerve and emissary vein. Lesser petrosal nerve and emissary vein. Okay. So, if injured, mandibular nerve being injured, it will cause contralateral movement through the side. Okay. That is the, if one side of the nerve, that was not mentioned which side of the nerve is involved. It was just involved that muscles of mastication and deviation of the jaw. So, we have got the contralateral movement of the other side. Now, let's move on to the foramen rotundum. So, foramen rotundum is not the answer. Why? Which structure pass through foramen rotundum? Maxillary nerve, and maxillary nerve is not innervating muscles of mastication. It is not involving muscle of mastication. Now, foramen spinosum, which structure pass through foramen spinosum? Which structure pass through foramen spinosum? Middle meningeal artery and recurrent branch of middle meningeal artery and the recurrent branch of the meningeal. So these are the structures not involved, so this can't be the correct answer. Also foramen lacerum can't be the correct answer. Why? Because meningeal branch of ascending pharyngeal artery nerve traverses through pterygoid canal, and generally at times it is occluded by that of the cartilage. So this is the reason it can't be the correct answer, foramen lacerum. Now jugular foramen, okay, jugular foramen is traversing through the jugular foramen. The structure traversing is 9th, 10th and 11th nerve, the inferior petrosal nerve, the sigmoid sinus and posterior meningeal artery, Got it everyone? Got it everyone? Okay. So yes, we have done with this. So we have now, before moving on to the what are the side nerve involved? So pterygoid muscles is yes, contracting and causing side to side movements of the contralateral side. If it is moving contralateral side, so if it is injured, so it will be deviated towards the same side. Okay, it will be deviated towards the same side. So just same as like the explanation. Done? Is it okay? Can we move on to next question MCQ? Everyone? Ali, yes. Okay, yes. Okay, Meet, yes. Okay, okay. Now, before moving on to the next MCQ, I just want to tell you that FMGE exam 2021 is going on to on the June 18. So I am taking two sessions. One is 7:15, Dr. Animesh, yes, 7:15 क्लियर नहीं दिख रहा है मैम, कुलदीप, okay. So all others, can you see the screen nicely everyone? So few students are telling others, is the screen clear? Yeah, so screen is clear. So 7:15 and 7:15 is the timing for 15th and 16th June session. So this is my Telegram group Mona Lisa Anatomy. This is the Telegram group Mona Lisa Anatomy. So you can join my Telegram group. Yes, Meet is telling it's clear. Every other one is telling clear. So I think Ali, you have to check your connection. So yes, you can join the group for the links of my session. Also, Let's Crack NEET PG group you can join, and you can, those who are new to the platform, those students who are new to the, so tomorrow I am taking 7:15 PM session on the Unacademy platform, where I will discuss most important MCQs of the previous years. So those who want to join, they can join me. Okay, and those who are new to the platform, they can use the code ANAT10 for unlocking free sessions on the Unacademy platform. 9 PM session is for MCQ discussion. So 9 PM again I am taking the MCQ session. Those who want to join, they can join me. Iconic subscription, those who want to take the Iconic subscription, they can get the benefit of both live sessions of the Unacademy and also the prep ladder, live classes and batch courses, video lectures, Q bank. Okay, these can be assessed. Also rapid revision courses, live test and quizzes can be assessed by you. Okay, and also you can be the part, so you have to use this code ANAT10 for 10% discount. So those who want to prepare for they can take either 3 months of subscription and get 1 month of subscription absolutely free. They can get 1 month of subscription absolutely free. Those who want to take the subscription, they can take 12 months of subscription and they can get 2 months of subscription absolutely free. Okay, now download the Unacademy app and use the code ANAT10. Just download the Unacademy app and use the code ANAT10 for the subscription, and you can take the subscription according to your needs, whether you want more, you have got more time for your deadline of preparation, then you can go for yearly, 2 years or monthly subscription. Satyajit, yes, absolutely Satyajit, it will be very beneficial for you. You are the student of AIMS first year, because there is prof courses also going on. Prof courses are there, and next targeting MCQ session. So it will be very beneficial, because anatomy MCQs you can practice, and there is prof sessions, first year, second year, third year prof sessions are also on the platform of Unacademy. Live sessions are there. Every fourth session is a doubt clearing session, and if any time due to your academic load or ANAT 10 is the code, ANAT 10, okay, my code is ANAT 10. Okay, ANAT 10 is my code, it is written here, you can see in the screen. ANAT 10 is my code, which can be used by you if you want to take the plus subscription. And also first year students courses are there, so I am just giving you the information, don't worry about this. So these are the benefits of plus courses: structure courses, unlimited SS, weekly test, live sessions. So courses are next, so everyone has to give next, so you can just be the part of next. You will get 10% discount if you use the code ANAT 10. NEET PG session is there, so again you will get 10% discount by using the code ANAT 10. You have to download the Unacademy app, and then you can go for taking the subscription. Plus MBBS third year batch is there, you can join that batch. Also there is MBBS first year batch. So yes, who is the first year student? Satyajit, you can join the AIMS first year. Very good, nice, AIMS student. So yes, you can start your preparation from now itself, and this will be useful for cracking your theory and practical Viva examination. So ANAT 10 is the code which can be used by you if you want to take the subscription of the first year. So one of my students from CMC Vellore has taken the subscription, and first year students can one time only go for 2 or 3 year subscription, and they can get the benefit of taking the live session of all the 3 subjects of first year along with other subjects also. So like this you can start your preparation. Okay, now second year batch is also there. So my dear friends, I have got few more MCQs. Can we go with the MCQs? Okay, can you? And don't worry, if any of the things I am not able to solve your doubt now itself, I will again see your comment. I will write the explanation in the comment. So please, if anything remains, at times I am concentrating on my MCQs writing or something. So if anything remains, you can just write in the comment section, ma'am, please explain this. I generally go through the comment section, and if anything you want to explain me once again, or any doubt, you can ask my doubt in my own group. Monalisa Anatomy is my Telegram group, so you can join there and you can ask your anatomy related doubt. Monalisa Anatomy is my group. I will in the end also show you. So let's start with this. So a 25-year-old male fracture. Okay. Okay. So see here, is having a fracture his tibia, and his right leg is having cast, but he is amputated. 2 weeks later he is not able to extend the wrist. So the key point is extension of the wrist. So you have to tell me which is the right answer: suprascapular, long thoracic nerve, axillary, accessory, or radial nerve. Yes, absolutely right, absolutely right. Yeah, so they are confusing you by giving which right tibia being involved, but the main sign and symptom is involvement of non-extension of the wrist. So difficulty in extension of the wrist. So the correct answer is radial nerve. Absolutely right. So patient is suffering from pressure induced radial nerve injury, which will be improper crutch fitted. Radial nerve is injured by its superficial location in the axilla, and it can be caused due to crutch palsy. Okay, injury to radial nerve leads to weakness and paralysis of the muscles of forearm and wrist, and ultimately will cause wrist drop. Now let's move on to the other option. Suprascapular nerve is not the right answer. Why, my dear friends? Suprascapular nerve is suprascapular nerve is innervating 2 muscles. One is supraspinatus and other is infraspinatus. So supraspinatus is causing initiation of abduction, that is 0 to 15 degree. Yes, Saturday night palsy is also one of the features of radial nerve compression, when there is compression on the spiral groove in the area on the posterior aspect of arm in the spiral groove. Infraspinatus muscle is lateral rotator of shoulder joint, but it is not causing wrist drop. So option A is not correct. Yes, initiation, Srija, initiation of abduction अगर involve होता तब we have the answer suprascapular nerve. Initiation of abduction was not involved, so this is not the correct answer. Now, long thoracic nerve, that is Bell's nerve serratus anterior. So, if Bell's nerve was involved, the winging of scapula, or it is generally involved in cases of lymph node dissection, radial mastectomy, and serratus anterior muscle is paralyzed, and the action which is affected is protraction of the scapula, and medial border is prominent, and the condition is called as winging of scapula. Yes, why not Mahazan? Okay, Mahazan, I am taking many of the sessions free for the first year students, and also there is on the Plus platform of Unacademy, there is a first year session, so you can join the Unacademy live sessions. You can be the member of Plus subscription for first year subjects. You can go for Prof subscription. So, and you can also get benefit from me. You join my Telegram group, you can ask your doubts, you can see my free sessions which is going on in the platform of Unacademy. So, you can just join. I will give you the link of my Telegram group, don't worry. Axillary nerve can't be the answer. Why? Because axillary nerve, when injured, axillary nerve is supplying which muscle? Deltoid muscle. So, when deltoid muscle is involved, what will happen? There will be paralysis of deltoid and teres minor muscle, and ultimately we know that deltoid muscle is causing abduction of shoulder joint. So, loss of abduction of shoulder joint will happen, and also cutaneous sensation over the skin of deltoid muscle will be affected. So, this was not the presentation of the patient. The presentation of the patient was loss of wrist extension. So, this can't be the correct answer. So, you can revise it also. I have written everything and details of explanation. So, don't worry about this. Preetham, yeah, free sessions I am, okay Preetham. So, yes, free sessions are there. So, many of the things I am covering in the free, but if you want to have a session from top to bottom and in a sequence, then you have to go for Plus subscription. There are many benefits of Plus subscription, but yes, that also depends if the student don't want to pay that much. So, don't worry, I will guide you with the free sessions also. That is totally up to you whether you want to take the subscription now or afterwards. That is totally up to you. If you can afford, you take the subscription. That is extremely beneficial because you will get the benefits of biochemistry and physiology also. But if it is not possible for you, then I will guide you on my free sessions. Okay, thank you. Accessory nerve is not the answer. Why? Because accessory nerve means 11th cranial nerve is supplying two muscle, trapezius and sternocleidomastoid muscle, and trapezius and sternocleidomastoid muscle, if it is involved, it is not causing it will be affecting it is mainly sternocleidomastoid muscle is a movement of the head to the other side, rotation of the head. Trapezius muscle is also elevating the scapula, shrugging of shoulder. So, these kind of sign and symptoms will be provided, but these kind of sign and symptoms was not provided in the MCQ. So, this can't be the correct answer. Okay. So, let's move on to question number 7. A 34-year-old male presents to the emergency room complaining of severe right shoulder pain after falling from a tree. The X-ray reveals a fracture in the middle third of the right clavicle, and medial end of fractured clavicle is displaced upward due to traction of which of the following muscles. So, 6 options are there. Please mark the correct answer. All of you, please mark the correct answer. 6 options are there. So, Srija is telling B. Okay, what about others? Laksha is telling B. Satyajit Bera is telling B. Okay. So, yes, most of the students are telling B, sternocleidomastoid muscle. Okay, yes, the correct answer is sternocleidomastoid muscle, and the hint was given by the medial end of fractured clavicle is displaced upward. So we have to know which muscle is attached on the medial aspect. We have to know the details of which muscle was attached onto the medial aspect of the clavicle. So yes, that is the hint which is provided. So let me come up with the explanation. Yeah, sternocleido, absolutely right. Sternocleidomastoid matlab muscle which is attached to sternum, which is attached to clavicle and also to the mastoid process. So see here, I have included this diagram where you can see this is the clavicle. Okay, this is the clavicle, and you can see the clavicle is broken from the medial aspect, and the end you can see it is pulled upward. Generally we have to know why the broken end of the clavicle can be pulled upward. So that is the pull of the sternocleidomastoid muscle, because that is the muscle which is attached onto the medial aspect of clavicle. So this will be clear once you know about the origin insertion. So actually the correct answer, the medial end of fractured clavicle is displaced upward due to traction. So the correct answer is sternocleidomastoid muscle, because this is the muscle which is attached onto the clavicle medial aspect, pulling it. So medial, actually sternocleidomastoid muscle is having two origin. One is the sternal origin, other is the clavicle origin. From the medial aspect of the clavicle it is originating and getting towards the occipital bone and all. So it is going in the upward direction into the mastoid process of temporal bone. Okay, so that pull is given by the sternocleidomastoid muscle pulling the medial end of the clavicle. So B is the correct answer. Yes. Now let's move on to the incorrect options and the other options. So what you can see, the rhomboidus group of muscle was given. So it can't be the correct answer. The reason is that it originates from rhomboidus minor and the spinous process C7 and T1. Okay, and rhomboidus major from the spinous process of T2 and T5 and inserting into the spine of scapula. Can you see it is inserting into the spine of scapula, root of the spine and the vertebral border of the scapula. So you can see none of these muscles are attaching to the clavicle. So this can't be the correct answer. Rhomboidus can't be the correct answer because it is not attached to the clavicle bone. So how come it is pulling it in upward direction? Got it everyone? So it can't pull it in upward direction. So yes. Now also what you can see, the neck. Yeah, rotator cuff muscle. Yes, we have got lateral aspect also is having the other muscles being attached. Yeah, so medial end is so the option which was given. So let's move on to the pectoralis minor muscle. Yes, you have to know the attachment of trapezius, deltoid, sternocleidomastoid muscle attached on which part of the clavicle, and according to the attachment, whether the medial or lateral, you can approach to the right answer. But here that confusion was not given, because you can see other option was pectoralis minor, and we know it is inserted from on the coracoid process and originating from 3rd, 4th and 5th rib costochondral junction. So again pectoralis minor muscle is not attached onto the clavicle, so it can't be the correct answer. It can't pull it in upward direction. Okay. Okay, now one of the option was serratus anterior muscle. Serratus anterior muscle is attached onto the ribs, originating from the ribs and inserting into the medial aspect of the scapula medial border. Again not attached to the clavicle. So serratus anterior can't be the correct answer. Now if serratus anterior would have been the correct answer, the winging of scapula, then winging of scapula was sure shot given as an option. Winging of scapula as the presentation of the patient must has given in the option, but it was not given, so it can't be the correct answer. You can see the medial border of scapula is projected out like a wing when the person is pushing against the wall. Now let me tell you one subclavius muscle. Maybe this can't be this can be a confusion with you, because subclavius muscle is attached onto the clavicle inferior aspect. Which bone is this? This is the clavicle bone, and you can see on the inferior aspect or the subclavian groove, the subclavius muscle is attached from the first rib. from the first rib, as you can see, from the first rib going to the subclavian groove, but it is supporting the clavicle from inferior aspect. It is giving support to the clavicle from inferior aspect. Sternoclavicular joint is also supporting the sternum and clavicle, but none of these can be the correct answer. Best answer is sternocleidomastoid muscle, because sternal head is directly attached on medial aspect and it is inserting into upper aspect. It is going towards the mastoid process. So, its pull will, the pull of sternocleidomastoid muscle will pull it in upward direction. So, that is the correct answer, and most of you have given the right answer. So, yes, we have done with this. Students, before ending the session, I want to give you the details of my upcoming session. I want few more MCQs I wanted to cover up today, but don't worry, I will again take one more session, covering one more session I will take on clinical anatomy MCQs. So, don't worry about that, because from 9 PM I have to start another session. So, let me just tell you about my upcoming session. So, let me just come to that part. So, yes, myself Dr. Monalisa, and I have done my MD Anatomy from Armed Force Medical College, Pune, and those who are interested for free sessions of mine, they can join me. They can join me with the code ANAT10 on the Unacademy platform for special classes. They can join me for the special classes, and my tomorrow's session of Anatomy MCQ discussion is tomorrow is 15 June, 7:15 is the timing of FMGE MCQ session. On 16 June also I am taking FMG MCQ session. Those who want to join, they can join. And yes, my Telegram group link is here. So, all of you can join me Telegram group for your doubts related to anatomy MCQs. You can join me there. Free sessions also, just now from 9 PM I am starting free session on the Unacademy platform. So, those who are interested for anatomy MCQ session, again they can join me on the Unacademy platform. Unlock code for seeing my session is, this is the Telegram group link, Monalisa Anatomy, and unlock code is ANAT10, which can be used by you. Yes, Satyajit, and also I want to tell that I am also taking free sessions for first year students. So, I have completed so many topics. Tomorrow is the heart topic, last topic tomorrow I will cover up. Few more topics like lungs, pleura, heart, azygous venous systems, trachea, esophagus, thoracic duct. So, I am taking free sessions for the conceptual anatomy. This is beneficial for first year MBBS students. So, these are free sessions. Those who want to join, they can join my Telegram group, where the link of my sessions are shared. So, there the link of my sessions are shared, Monalisa Anatomy, and also they can use the code ANAT10 for being the part of my sessions. Okay. So, all the best, keep studying. Thank you so much. So, we will again meet with the sessions, upcoming sessions. So, few more MCQs I will discuss, clinical MCQs, which will be beneficial for you. So, anything more, any confusion, if I was not able to clear, agar aapka koi bhi confusion hai, I was not able to clear, you can just write in the comment box, I will explain that there. Okay, all the best, keep studying. So, now I have to start 9 PM session. So, few more MCQs were there to discuss, but I am just 10 minutes only to go for 9 PM session. So, I will just end the session. Thank you so much. All the best. Keep studying. Thank you, students. Thank you.